newly graduated doctor from UCL, and I'm working at the Whittington at the moment. We've just been chatting a little bit about how lots of people from other universities, and I hear that your exams are coming up a lot sooner than UCL's, so hopefully this session will be reassuring, cover lots of the sort of core conditions in RESP, as well as give you some questions to see how you're getting along. So I'm going to spend a bit more time on the starred subjects, asthma and COPD, just because they're a bit more common, higher yield, and then we'll go through briefly the other things. First question, sorry. So I'll give you a bit of time to read it, and then we'll go through. Great, so poll's open now for you to vote. And then just 5 more seconds. Perfect, good. So 84% of you got that correct, with most people who got it wrong going for C instead. So we can just talk through the correct answer being D, salbutamol inhalers. So here we've got an 18-year-old girl who's got a strong family history of asthma. She's presenting with some exertional shortness of breath and also a nocturnal cough. So the doctor pretty much thinks she has asthma and is planning on investigating that, but in the meantime wants to start her on some treatment. And the best treatment, first line, would be a salbutamol inhaler that she can take when she needs. The main reason for that would be that sort of a positive response in terms of improving her symptoms would actually be beneficial in terms of helping the doctor be more certain about the diagnosis. 12% of you thought the answer was C, steroid inhaler. So that would be the first sort of preventative rather than relieving measure in the asthma management sort of escalation plan that we're going to talk through in a bit more detail. So I can see why you'd think that, but you wouldn't start that unless sort of PRN salbutamol wasn't enough for the patient. And the other options, if we can just talk through briefly, so oral prednisolone is something you would give somebody who is having an acute flare of established asthma. You wouldn't usually give it when you haven't yet made a diagnosis, and certainly when you haven't yet tried salbutamol or any other more simple agents. Leukotriene receptor antagonist, that refers to the medication montelukast, which falls much later down in the asthma management plan. And ipratropium bromide inhalers, that's your antimuscarinic agent. That's more for COPD, although it can be used as a nebulizer in acute asthma. So here if we just talk a little bit about asthma in general, it's very common, more so in children and up to 10% of adults as well. It's a chronic inflammatory airway condition, which is caused by something that's triggering type 1 hypersensitivity reaction in the body. And it causes recurrent reversible airway obstruction in three different ways, which will work together to produce that obstructive effect. So you get a bit of extra mucus, the actual muscle and lining of the bronchioles are inflamed, and you also get like muscular bronchospasm as well, which all contribute to narrowing that lumen and obstructing airflow. Different triggers happen for different people, pet allergens, cold weather, exertion, dust, other sort of aerosolized sprays. So it's very important that you find out for the patient what that is for them. And it can have a really big impact on people's quality of life if it's not well controlled. This is particularly important in children in terms of helping them maximize their potential. And these things here, sleep, days off, and whether it affects their ability to function, are things that you should talk about in your histories with patients in terms of gauging how well their asthma is controlled and how severe it is. And then other little fun points of interest that occasionally come up in SBA land is something called Samter's triad, which is a collection of asthma, aspirin sensitivity, and nasal polyps. So it might just ask you which other symptom or sign is most likely to appear in a patient with the other cluster of symptoms. And there's also an interesting sort of phenomenon of PPI resistant GORD in asthmatic patients. So they get reflux type symptoms often, and that won't really be helped by PPI medications as it usually would. But interestingly, improvement of asthma control does tend to help the reflux symptoms as well. In terms of the chronic management plan in more detail, so the main aim is complete disease control, and respiratory physicians will always say sort of anything less than complete control is suboptimal. The first thing you're going to do is give them the short-acting beta agonist, that's the salbutamol, and they can use that as and when they need. But a sign that that isn't enough for a patient is if they're having to use that more than 3 times a week or more than 1 night a week. So if they're having to use any more than that, that's when you should be thinking about if they need another agent. And importantly, when you give it to a patient, you should always tell them if they're having a really sort of acute episode of their symptoms. They can take 10 puffs in 10 minutes, sort of one after the other. And if that's not significantly improved things, that's a sign that they should call for help. So either 999 or whatever is appropriate in that time, depending on where they are. So if the salbutamol isn't enough, that's when you step up to the steroids, which is what some of you mentioned in the previous question. You're starting a low dose of steroids, and that's if the patients are having symptoms more frequently. And then at that point, if that's not controlling it, it's really important that you just recheck whether the patient's taking their inhalers at all, and if they are taking them, whether they're taking them correctly, because that can have a really big impact on delivery of medications. Inhaled medications are notoriously difficult. And also to have a more thorough discussion about triggers. So some patients you might find with occupational asthma, particularly people who work in areas of industry where there's aerosolized particles around. So they might have asthma on weekdays and not at weekends, and that can be a really useful thing to work out early on. You can try and think about adaptations and occupational health for that patient in terms of trying to remove that trigger for them as much as is possible. Then you're going further down the ladder, so that's when you would trial your montelukast, and importantly that is a trial, so if that's not improving the patient's symptoms, you shouldn't keep them on it as you escalate up the ladder. It needs to be having some sort of beneficial effect for it to be worth them still taking it. If that's not enough, you're going to add in a long-acting beta agonist medication. Usually it's called salmeterol. That's in with the inhaler that's a steroid, and they take that in the morning and in the evening as they were taking their preventer inhaler previously. If that's not enough, then you can swap that for something called a marked inhaler. That's a maintenance and reliever inhaler. So it's got a short-acting form of the long-acting salmeterol version. It's called formoterol, if that makes sense. So they can take that in the morning and in the evening. It has a preventive action, but it also has a fast-acting relieving action. So they can take it PRN as well. If that's not enough, what you need to do is gradually increase the steroid component. So first of all, they can take the moderate dose as a maintenance and reliever inhaler. But if they're requiring high dose steroids, you need to split that inhaler up again. You don't really want them taking high dose steroids PRN. So in that instance, you'd give them the regular twice a day high dose steroid inhaler, plus you'd give them the lower dose LABA long acting beta agonist inhaler that they can take as well. And then basically any further on than there, you're really needing to talk to a specialist, and it's becoming more niche. And it's important to mention that this is one area of medicine where there is some contention between BTS, British Thoracic Society, and NICE guidance. This was explained to me once as how NICE takes into account treatment efficiency in terms of economical value, and BTS is 100% sort of evidence-based best outcomes. UCL certainly have made it very clear on multiple occasions that they examine on NICE guidance, but it's definitely worth checking because this is an area that is sometimes different between guidelines. So this is the most recent NICE guidance, but you need to make sure that you're 100% certain that's the best thing for your university. So next question, I'll give you some time to read. And 5 more seconds. Okay, good. So people found this question a bit harder. So the correct answer would be B, spirometry. 32% of you got that right. So don't worry if you were confused. Nobody seemed to think it was C, chest X-ray, which is good. The chest X-ray's value would be in excluding other pathology rather than making a positive diagnosis of asthma. But basically, people were split between the other answers. So we can talk through it. Here we have an 18-year-old girl who's being investigated for asthma. And the question's just asking, what's the best investigation or the first line investigation in order to make a diagnosis? The correct answer would be spirometry. I'm going to talk a bit more about that in more detail, but it's the gold standard and it kind of tests airflow in and out of the lungs. And because asthma is an obstructive condition, it allows you to sort of directly visualize that obstructive effect and also confirm that it's reversible with your short-acting beta agonist medications, your salbutamol. So you do the spirometry, you give the salbutamol, and then you do it again 15 minutes later. And in order to make a positive diagnosis of asthma, you need to see both an obstructive pattern, which we'll talk about in a minute, and you need to see some reversibility. One-off peak flow readings are not very helpful in order to make diagnosis of asthma, because the whole point of a peak flow is that it's a comparison to the patient's baseline. So if you just have a single reading, it's not going to tell you much in terms of how the patient's doing at that moment. An at-home peak expiratory flow rate diary would be helpful. It doesn't allow you to make a definitive diagnosis in the same way that spirometry does, but a 2-week peak expiratory flow rate diary is often used because it's cheaper and more practical alternative, and wait times for spirometry can be quite long. But that would be 2 weeks rather than 1 week as per the guidelines. Exhaled nitrous oxide levels are a newer investigation. They're not really used in first-line diagnosis, but they're increasingly being used to monitor compliance with medication and disease control in general, and they may be used in more complex patients where the history is unclear and spirometry has come back indeterminate to aid diagnosis later on, but they certainly wouldn't be first line. So investigation of asthma, as I said, spirometry is the best diagnostic test, or you've got your 2 weeks of peak expiratory flow rate. The thing about peak expiratory flow is they do it a couple of times in the day, but most importantly in the morning and in the night. And they have what's called diurnal variation, where their reading is worse in the evening time. And that is because of changes in the endogenous levels of cortisol in the body. And that kind of explains why we use cortisol, or not cortisol, but steroid inhalers as part of our asthma management plan, because we know that naturally in the body at times when those levels are higher, the control tends to be better. Other investigations that we haven't already discussed, people with asthma can show an eosinophilia on their blood count, and it can be helpful to test them for other allergens just because they often come in clusters, so things like hay fever, eczema and other allergens to food or cosmetics can come together, as well as a treatment trial of salbutamol that we mentioned in the last question. A little bit about spirometry here. The main things to be aware of are things called obstructive and restrictive patterns. In your obstructive diseases, there's difficulty getting the air out of the lungs. So FEV1, which stands for forced expiratory volume in 1 second, how much air you can breathe out in 1 second quite quickly. And that's reduced in obstructive conditions. That's where you see the most change from normal, whereas your forced vital capacity is closer to normal. So they can fit a normal amount of air in their lungs. Their problem is getting the air out. That gives you a reduced FEV1 to FVC ratio, and that's the cutoff, 0.7 for sort of quantifying an obstructive condition. And then below here, you can just see that in terms of reversibility in asthma, there needs to be at least 200 mils or 12% reversibility, but that's improvement in their FEV1 value after they've had their salbutamol and when you repeat this spirometry. And then in terms of restrictive, the main problem there is that you just can't fit as much air in the lungs. So the FVC is significantly reduced. and the FEV1 is reduced, but that's kind of as a byproduct of the fact that there is less air in the lungs to begin with, which gives you a ratio of FEV1 to FVC that looks more like normal. However, it's because they are both reduced together. And that can be caused by things such as fibrotic lung disease, neuromuscular problems, and also pressure problems like obesity, hyperventilation, and pregnancy. Okay, so if you read this question. And 5 more seconds. Okay, interesting. So lots of you think that this is a severe flare. So let's talk through the question and see where the confusion may come. So here you've got a 37-year-old male who's presenting to A&E having an asthma attack, and you've been given his observations and his ABG and asked to clarify the attack based on its severity. So the key thing here is noticing that the CO2 on the ABG is raised. And so if you've got a high CO2, that would mean that the patient was having a near fatal asthma attack. So I'm not going to spend too much time on this because it's unfortunately, as many things in medicine at university, a case of just learning this list. So the critical thing here is near fatal asthma, the CO2 is raised. Life-threatening asthma, the CO2 is normal, so it's just a progression from that. And then otherwise, the main things to look at are just the peak expiratory flow rate. So that's sort of the main distinguishing factor between moderate, severe, and life-threatening, as well as this here, the ability of a patient to complete sentences in one breath is clinically a really big determinant of severity, and obviously immediately would bump the patient up to having a severe asthma attack. It's a really easy thing you can assess as soon as you walk into a cubicle with a patient. So a question will often tell you that patients are struggling to complete sentences or struggling to speak to you during your assessment, and that's an indicator that they're having at least a severe asthma attack. And then if a question gives you a ABG result, that's when it's important to just assess that CO2 to see if it's normal or high. The reason normal CO2 can actually be a bad thing in asthma is because if somebody's hyperventilating, breathing very quickly, what you would expect is for them to blow off lots of their CO2 as they're expiring, like more so than normal. So if the CO2 is normal or creeping up, despite the fact that you're breathing very, very quickly, that's a sign that the respiratory muscle effort is weakening and the patient's getting very tired, and that's very dangerous and means that they may well need intubation or higher level support very soon. Next question. And 5 more seconds here. Okay, good. So here we've got most people going for the correct answer of E, salbutamol nebulizer, and then a pretty much even split over the other options, slightly less people going for option A. So we can talk through this. We've got a 41-year-old male in the A&E department with acute shortness of breath. He's speaking in short sentences, but he does manage to tell you that he does have asthma, and his salbutamol inhaler so far has not been helping very much. His saturations are all right, 98%, although he is visibly working quite hard with his breathing. what agent should you give first in the emergency department? So if we work through it, IV magnesium sulfate is something that's given a lot further along down the acute asthma management pathway. Initially, you're starting with your more simple inhaled nebulized agents. So primarily that would be salbutamol, and also you can add in your antimuscarinic nebulizers as well. So that's ipratropium. And if that doesn't work, that's when you would progress on to other things, such as the magnesium sulfate infusions. You would be giving them steroids. However, here, there's no particular mention of any reason why you couldn't swallow a tablet, and so it's always important to choose an appropriate route. So probably this patient would get oral prednisolone rather than IV hydrocortisone, and certainly that would be less of a priority than the nebulizer, even if this option had have been oral prednisolone here. Option C, 15 litres of oxygen via a non-rebreathe mask, probably would have been the correct answer if the patient had been critically hypoxic, as that would sort of been the most urgent thing to just whack on while you prepared the nebulizer. However, the patient here is saturating quite well, so that's not as important as giving the drug that's actually going to help relieve some of that obstruction. I actually discussed this question with Yazin when we were writing it. You might read in books about 5 milligram salbutamol nebulizers being the sort of dose. However, when you go from 2.5 to 5 milligrams, Yazin was explaining to me, you get more of a tachycardic response with not that much improvement in its kind of bronchodilatory therapeutic effects. So actually, 2.5 milligram nebulizers tend to be used more in practice. So if we're going to go through the acute asthma management here, as I said, the first thing you'd do if the patient is struggling to saturate would be to give them oxygen, and then you're going to use your nebulizers. And that's given in something what we call back-to-back, which means you can basically give them one after another. It takes 15 minutes to half an hour for a nebulizer to run through, and if the patient's still struggling with their breathing, you can just put another one on. It's a relatively safe drug, salbutamol. It can cause some tachycardia, but you also need some cardiac monitoring because it can occasionally cause arrhythmias. So it's just a case of keeping a close eye on that patient, which you hopefully would be doing anyway if they're having an acute asthma attack. Throughout this sort of period, you're assessing the severity of the asthma attack, and as soon as you start to be more worried about that patient, you would be alerting ITU in case they do need a transfer later on. It's always better to have more people involved and be sort of over-prepared than it is to suddenly have a patient deteriorating and not know if you've got space to transfer them to a higher intensity unit. So as I said, you're then giving your steroids either orally or IV, depending on patient situation. And you can repeat those nebulizers, and you can add in your antimuscarinic nebulizers too. They have more of a limit on how often they can be used, only 4 times a day, but they can be given at the same time as salbutamol, 2 agents in 1 nebulizer. And then the patient will either improve. If they improve, you can monitor their progress with their peak flow and their SATs, wean them off the nebulizers gradually. The patient may be able to go home very quickly if they've improved very rapidly, or they may need to stay in overnight while this weaning process happens. And so here, if the peak flow is more than 75% at only 1 hour post presentation with their attack, that's when you can consider your early discharge. Otherwise, they're probably going to need to come in and be monitored more closely. And then if they're not improving, that's when you escalate up. You've got your IV magnesium sulfate, and you should refer to ITU. They might need things like IV aminophylline and IV salbutamol, or even invasive ventilation, and they're not generally things that we give on the ward without higher level monitoring. Okay, next question. Okay, I've got some feedback that you'd like a little bit longer, so you can have a bit longer for this one. Apologies for rushing through before. 10 more seconds here. Okay, great. So most of you got the correct answer here. That's B. So let's talk through this. We've got the respiratory team planning the discharge of a young man who was admitted 2 days ago with an asthma attack. It was a recent diagnosis of asthma, and his sort of current management plan that he was working with was using a steroid inhaler regularly, as well as PRN salbutamol inhaler. This is his first attack, and he hasn't got any other medical issues. So you're planning his discharge, and which of these things needs to be done in order to make sure he's safely discharged home? So the most important thing to do would be to review the patient's inhaler technique and compliance. Unfortunately, young people in general tend, particularly teenagers, tend to have higher levels of not taking or forgetting medications. So compliance is important here in particular, as well as technique. He's newly diagnosed, maybe he has forgotten how to use it properly, or wasn't necessarily shown how to use it properly, or needs a bit more support with that. And that's important, not to just escalate the patient up a management plan without knowing if the current management plan is even being used to its maximal effect. The other options, referring for an outpatient appointment. Nice advice that you would do that if they're having 2 or more flares within 1 year. So this patient's having his first asthma-related admission, so that's not necessary. Prescribing a course of rescue steroids for the patient to take if they have more symptoms in the future. That you might do for patients who have sort of very predictable seasonal exacerbations to try and avoid admissions. That doesn't seem to be the case in this man, and you wouldn't want to be giving somebody steroids to take home unless they really needed them, because they are a drug with lots of side effects. Switching around their inhaler regime, we've kind of addressed that. You wouldn't want to change anything if you weren't certain they weren't using the ones they already had properly. And then referral for home assessment by occupational therapy. That's sort of more something you would do for patients where they had complex social issues or you're a bit worried about them at home. But there's nothing in the STEM to kind of suggest that with this man. Sorry, the slide's not moving on. There we go. So asthma and safe discharge. In order for them to be kind of close enough to their baseline, you want their peak flow to be more than or equal to 75% of their baseline or their predicted peak flow. If that happens very quickly in A&E, they can always be discharged directly from there. But if not, then they need to be admitted. And once they're admitted, the criteria that needs to be met is stable on inhalers only for 24 hours. So that's not requiring any nebulizers or oxygen support. It's important to review their inhaler compliance and give them a written plan, so there's 100% no confusion that they don't know what to do in terms of looking after themselves and their asthma control. You often would give a 5-day course of oral steroids to complete at home, but as with most things in medicine, that's not an always. You need to let their GP know on the discharge summary, and usually, because there's a delay in getting discharge summaries to patients, that would involve calling them to let them know the patient's there, so they can organise a review within the next 48 hours for that patient. And then they're usually seen in the respiratory clinic within 1 month if once they've been discharged, and that needs to carry on for 1 year of follow-up if they've been admitted, or for life if they've had to stay on ITU with their asthma, because they would be a high-risk patient. And then here's just a nice example that I like of a personalised asthma plan. You can have a closer look at this in your own time, but it's very good practice to kind of give patients very clear instructions so they can understand what good control should be, because some patients who've had poor asthma control for a long time, they don't really understand what they should feel like on a normal day. So it's important to kind of explain to them what is a sign of poor asthma control and when they need to do X, Y, Z. Okay, next question. Moving on from asthma now. 5 more seconds. Great, so almost everybody got this right. So here we have a 60-year-old man who's got a 40-pack year of smoking history. He's coming to his GP with increasing shortness of breath on exertion for quite a long time, so over a couple of years. He gets wheezy sometimes, particularly when he gets a cold in the winter. He hasn't lost any weight and he's not breathless at rest. So the GP thinks that he's got COPD, and the question's asking, what's the single best intervention to improve the patient's prognosis? So COPD is one of the kind of most clearly preceded disease processes that we know of in medicine. Very, very clear link with smoking. And so as such, smoking cessation is the best thing you can do to improve your prognosis. It is a progressive condition that will continue to get worse if you continue to smoke. And it can be difficult to talk to patients about that, but it's important that you kind of make them clearly understand that so that they are making an informed decision of the risks of continuing to smoke. Salbutamol inhaler first line is used more so in asthma than COPD. An ipratropium inhaler is used in COPD, but again, like all of these inhalers listed here, they don't really affect the prognosis. They're more for symptom control. Graded exercise regime, I would say, is probably the other answer that I would have been choosing between if it was me. Sometimes called pulmonary rehabilitation, a thing that patients can be referred to. It's like a special course that patients can go on with psychological support for dealing with breathlessness and anxiety, helping them quit smoking, as well as special physio exercises to increase respiratory muscle strength. It has a really, really big effect on patients' quality of life, but still doesn't really compare with quitting smoking in terms of its effect on the prognosis of the patient longer term. So just a bit about COPD in general. Again, it's common. It's chronic and it's an obstructive airway condition, similar to asthma in that respect. However, it has little to no reversibility, so that's the key distinction from asthma. And it's important, like I said, to tell patients it will progress if you continue to smoke. It can look similar to asthma, so there's some key things to look out for to tell them apart in question stems and in life in general. A smoking history, if a patient is older at age of onset, so it'd be quite rare for someone to get to their late 30s and not have had any asthma symptoms before if it was a diagnosis of asthma. Chronic shortness of breath, rather than sort of with asthma, which may be more like with distinct triggers or certain seasons worse than others. And a productive rather than a dry cough. So they do tend to produce a bit more sputum in COPD with minimal variation that's distinctive of asthma. Spirometry, again, would be best for diagnosis because you need to kind of categorize that obstructive element of the condition. And it's the FEV1 that determines the severity of COPD. So obstructive's in the name, FEV1 is kind of showing you the degree of the obstruction, and it's that quantifies how severe you would say the patient's disease was. And here I just put a chest x-ray. It's important to do this in patients with COPD. You can look for complications that can happen. So if they have emphysematous COPD, they might get bullae, which can rupture and cause pneumothorax. So you can see that. You can also see early signs of malignancy, which is important and to catch early. And generally, patients with COPD will have what's called a hyperinflated chest X-ray. So here you can see some signs of that. There's a bit of a narrow heart. The lung fields are quite expanded. And there's also a flattened hemidiaphragm because they're sort of the air's pushing it down. And you can count more ribs than you normally would in a chest X-ray. Okay, next question. And 5 more seconds here. Great. Again, most half of you got the right answer, but it was pretty much the rest of you were torn between. I can see why you were thinking those things, so we can talk through it. The correct answer would be D, Venturi, and that's because it's the only real method of oxygen delivery here that's, I mean, A, the most appropriate, and B, controlled oxygen therapy. That's the key. So we've got a 65-year-old man who's got known COPD. He's coming to the emergency department with shortness of breath, and you've been given his observations on his blood gas. And then it's saying at this stage of his assessment, what oxygen delivery system is most appropriate. So the key thing here to look at again, as before with the asthma, is to hone in on the patient's CO2 level. Here you can see the patient's CO2 is high. So the thing with COPD patients is that over time they can develop a loss of their high. So normally people rely on what's called a hypercapnic drive. So when I or you are breathing, it's the levels of CO2 in our blood that kind of motivate us to breathe in and out. Some COPD patients, not all, will lose that, and they start to rely on their hypoxic drive instead. That means that they generally can tolerate a lower level of oxygen saturations compared to other people who don't have this long-term loss of hypercapnic drive. And in that way, because they're reliant on the hypoxia to sort of motivate them to breathe, giving them too much oxygen can be dangerous and can lead to respiratory arrest. And for these patients here, where they are CO2 retainers, it would be important to give them controlled oxygen therapy via a Venturi system. You can see here the special valves. There's different valves. You put them at certain liters per minute of oxygen flow, and it gives a definitive percentage of oxygen. So it doesn't mean we're giving the patient low concentrations. Actually, Venturis can go up to quite high concentrations of oxygen. It just means that we know for definite how much oxygen we're giving that patient. So some of these other methods of oxygen delivery, like nasal cannula, non-rebreathe mask, simple face mask, although we have a vague idea of how much oxygen we're giving, we don't know exactly how much. So that's the real key here. In terms of NIV, non-invasive ventilation, using a BiPAP machine, that's helpful in patients where you've already tried controlled oxygen therapy and your ipratropium nebulizers, and you've really tried to get them, get their COPD under control, and it's not working. And you're finding that the oxygen you're giving them is making their CO2 creep up and up, and you need to do something to help the patient blow off the CO2. And that's when you would put the patient on BiPAP, because what that does is it's a tight-fitting mask to the face, and it blows air in and sucks air out of the patient, and really helps take the workload off of their respiratory muscles and allows them to more effectively blow off some of that CO2 in the way that they're not able to do normally, because they've lost some of their respiratory muscle strength because they're tired from breathing quickly. It's important that you do a blood gas, because as I said, this is for some COPD patients, not all. Some other patients with COPD will not retain CO2, and so they'll be able to tolerate higher levels of oxygen more safely. So it's just to be really key that your oxygen saturation targets and the oxygen delivery system are different depending on if the patient is a CO2 retainer to if they're not a CO2 retainer. And the only way to know that is by checking the CO2 on a blood gas. Next question. Okay, 5 more seconds here. Great. So before I talk through this question, I'm just going to mention something that's come up in the Q&A. A couple of people are asking about why you're not using a non-rebreathe when the patient's stats are quite low. So that's a really good question. And I think non-rebreathe would probably have been the correct answer to the question on the previous page if it weren't for the fact that you had their ABG result, which showed a high CO2. So in a patient who's not a CO2 retainer, sats in the 80s, of course, you'd put them on the high flow oxygen. However, there's a possibility that that's going to do more harm than good in patients where you can see on their ABG that their CO2 is high. So that's the reason that the answer was not non-rebreathe mask. And probably that patient would have been put on a non-rebreathe mask with saturations of 80 something whilst the ABG was being performed, and then they would have been switched to a Venturi. But that previous question was specifically asking, with the ABG in hand, what was the most appropriate answer? So now to move on to this question here, we've got a 62-year-old man who's seen in the respiratory clinic. He's got known COPD and he's got persistent breathlessness despite having given up smoking and despite being on maximum medical therapy for his COPD. So taking all the inhalers, doing everything he can, it's just not helping. He's still got lots of breathlessness. His oxygen saturations in clinic are 87%, and he's got 2 ABGs here, one from today and one from 3 months ago. The question's asking you what's the next most appropriate intervention. So what the question's really asking is whether you know your indications for long-term oxygen therapy. So the primary indication is a PaO2 of less than 7.3 consistently, so on 2 ABGs more than 3 months apart. So that's the case here. And then there are some other criteria, which I'll go through on the next slide, of when in other instances you might give a patient with COPD long-term oxygen. Just to go through the other answers, intubation and ventilation here is unlikely to be appropriate in this patient who's quite stable, really. Although his blood gases are not good, and on me or you, that would make us critically unwell. This patient is adjusted to living at those levels of hypoxia. He's not about to deteriorate like that. He's stable and he doesn't need invasive ventilation right now. Low dose opioids to help manage his breathlessness is something we sometimes do in palliative patients. However, here for this patient, although it might improve his symptoms in the short term, it would just push him into further type 2 respiratory failure as his rest rate decreases and his CO2 would climb up and it would make him more unwell. So that would be inappropriate. Referral for pulmonary rehabilitation is something that probably would have happened earlier on in the patient's disease management. As it says here, he's on maximal medical therapy. He's probably already tried that. Also, it doesn't address the hypoxia, although it would probably improve his quality of life. So, and then the last one we haven't discussed is BiPAP. And again, that's generally something they progress to after having tried long-term oxygen therapy first. And also the patient needs to be in type 2 respiratory failure for BiPAP to be appropriate and sort of have its most therapeutic effect. And this patient here has a normal or slightly lower than normal in the 3-month ABG of CO2. So we're not worried about type 2 respiratory failure here just yet. So here, long-term oxygen therapy, clinically stable non-smokers, very important that they don't currently smoke because oxygen is flammable, so you can't have them lighting up nearby to the cylinder. As I said, chronically hypoxic with PaO2 of less than 7.3 consistently, despite maximal treatment, or a PaO2 of less than 8 is also acceptable as an indication for long-term oxygen if they've got secondary complications of their COPD. So that's polycythemia, that's raised red blood cells, pulmonary hypertension, nocturnal hypoxemia, or peripheral edema, just signs that the patient's struggling and slightly decompensating from their hypoxia. And then also in terminally ill patients for comfort, it can help ease the breathlessness at end of life and towards the end of life. So just some basics of ABG interpretation, because I know I found this really difficult. The first thing you need to look at is the pH to decide if it's high or low, if it's acidotic or alkalotic or within normal range. And once you've looked at the pH, you can then look at the CO2 and the bicarb are the most important things. And I use the acronym ROAM. I still say it to myself in my head every time I look at an ABG. respiratory opposite, metabolic equal, and that sort of refers to the relationship between the pH and then the CO2 and the bicarb. And by seeing which direction they go in and whether that's the same direction or opposite directions, you can see whether it would be metabolic or respiratory in origin in terms of the derangement of the pH. So in a respiratory cause of derangement, then the CO2 would be going in the opposite direction to the pH. They can either have CO2 retention, their CO2 will be high, that's if they're tiring from too much sort of respiratory exertion, or from over-oxygenation in COPD patients, as we just discussed, or in other patients with type 2 respiratory failure. Or it can be low, CO2 can be low, and that's from hyperventilating in normal physiological response to just breathing very quickly, you blow off lots of your CO2. Then you would look at your bicarb, and again, that can tell you, A, if there's a metabolic element to the derangement, but also if it's a respiratory cause, it can tell you whether it's acute or chronic, because if the bicarb started to move in the direction expected, then you can see if it's compensating, the body's working to compensate, and that would show you that whatever's going on in the body has been happening for quite some time, because it takes, you know, a couple of days at least for the body to start to produce a significant compensatory response. So if the bicarb is within normal range, then it's telling you something's very acute. And then the PaO2 just tells you how hypoxic the patient is. So it should be about 10 kilopascals less than the percentage of oxygen that they're inspiring. So room air is 21%. You'd expect the ballpark figure of our PaO2s to be 11. So if the patient was on a 40% Venturi mask, their PaO2 should be 30. So it can show you the degree of hypoxia. Okay, next question. Five more seconds. Okay, so lots of you have fallen into the trap, I suppose, that this question sets for you, which is knowing that a CURB 65 score of 2, which this patient has, would indicate hospital admission. So by the book, yes, that is true. However, when you dive into this question, you've got a 66-year-old man who's got dementia presenting to his GP with a cough and fever. So, you know, you're thinking he's got pneumonia, you're working out his CURB 65. So he's 66, that's a score of 1. His urea is not mentioned because it's in primary care. His resp rate is under the cutoff, so he doesn't score for that. His blood pressure is over the cutoff, so he doesn't score for that. But his AMTS is 7, so he gets another point for that. So he's got 2 points. It's saying where should he be managed. Now, the important thing to think about here is in a patient with dementia, that AMTS score is actually not too bad. It's likely to be his usual AMTS score, and it's not likely to represent confusion as a result of the infective process. Therefore, you kind of need to read between the lines a bit and think that bar his fever, his other observations aren't too bad, and it'd probably be more appropriate for this patient with dementia who's probably prone to getting disorientated easily, probably wouldn't do that well in hospital, to go home and to be managed there. So just generally going through the CURB 65 system, so you seem to know it well because you followed it in the previous question. You've got your confusion, urea of more than 7, resp rate of more than or equal to 30, blood pressure, being shocked, and age of more than or equal to 65 years. Importantly, in primary care, you kind of omit the urea aspect because the bloods aren't going to be immediately available. CURB-65 score of 0 means the patient's definitely safe to be managed at home. A CURB-65 score of 1, if the patient is not hypoxic, means they can stay in the community and have oral antibiotics. 2 would mean they would need IV antibiotics, so they should go to hospital. However, as we discussed in the previous question, that man's AMTS is likely to be chronic. 3 would indicate an ITU review, and 4 would indicate that ITU would probably be appropriate for that patient. It's important to realize that everything is flexible within medicine and everything needs to be done on a patient-by-patient individualized basis. So, you know, a CURB-65 score of 4 for me or you would be horrendous, whereas in a very elderly patient, for example, ITU might not be suitable or appropriate or really in the patient's best interest. So you've always got to think about the holistic element of decision making when it comes to care for these sorts of things. I've put in this slide here about choosing antibiotics in pneumonia. It's important just to understand that this is going to be trust dependent, and your trust guidelines are going to take into account local antimicrobial resistance patterns within the community of the hospital. So they're always going to be the best things to look at in terms of choosing antibiotics. But for exams, for general principles, this is something you can work with. You're looking at whether someone has a penicillin allergy or not, and then you're looking at how severe their symptoms are, whether their CURB-65 score is low or high, where they're being managed. So that's going to tell you if it's oral or IV, and it's going to tell you whether you can use penicillins, you know, your beta-lactam agents or not. And the most important thing to kind of flag is this grey area where you've got patients who have a mild reaction to penicillins, but in cases where they're very sick, a cephalosporin, which has a small amount of cross-reactivity with the beta-lactam agents and has the potential to cause a reaction in around 10% of pen-allergic patients, could be given on a sort of risk-benefit analysis in these patients because of the severity of their symptoms. But they would not be given to patients who have a full-on anaphylactic reaction to penicillin. So it's just mainly to flag that up to you. Okay, next question. Five more seconds. Great, basically all of you got this right. It's a very important part of working in a hospital is knowing about how to make it safe for patients to go home and what needs to be in place in order to manage that. So you've got a 32-year-old lady who's being discharged after an inpatient stay with pneumonia. She's otherwise well. And what must be organised as part of her discharge package? Well, for anyone who's come in with a pneumonia, you would want a repeat chest X-ray in 6 weeks' time. The reason for this is you want to check that everything on her chest X-ray is resolving. There's no residual damage to that area of the lung, like bronchiectatic damage. It can be difficult to see on a chest X-ray, but you can sometimes see it, as well as just generally there might be some residual consolidation there. And also, most importantly, and more relevant in older patients, is to check that there's no underlying malignancy, because paramalignant pneumonias are very common. Other things that could be done as part of her discharge package here, so pneumococcal vaccination, that's given to people at age of 65 as a one-off vaccine, or it's given to people who are following in like risk groups, so immunosuppressed or sickle cell, and they get it every 5 years. There's no mention of either of those things in this question to them. Spirometry would be unnecessary just for a one-off episode of pneumonia. You might organise it if you think the patient has long-lasting damage from the pneumonia, like further down the line, but it wouldn't be organised as standard. An outpatient appointment in 2 weeks' time, again, wouldn't be organised as standard, particularly not for somebody who's got such a sort of clean medical record. It might be organised if it's someone you were very worried about with a more complicated history. And again, as in a previous question, home review by occupational therapist is unlikely to be necessary in a young patient who's otherwise well and not got any social concerns. Okay, next question. 5 more seconds. Great, okay, so that's 66% of you think that the answer is D, which is correct, pneumothorax. And then quite a few of you picked pulmonary embolism, so we can talk about why that would not be as likely. We've got a 22-year-old man with a history of cannabis use. He's in A&E, he's got sudden onset chest pain on the right. It's definitely pleuritic, you know, when he breathes in it's worse, and he's very anxious and he's asking for morphine. On his observations, you can see that his breathing is very quick and he's hypoxic. So that's pointing towards respiratory pathology. What is the most likely diagnosis? So panic attack, you would expect high respiratory rate, but there's no pathology in the lungs, so there's no reason for the patient to be hypoxic if they were having a panic attack. Drug-seeking behavior, again, they wouldn't necessarily have pathology if they were presenting purely with drug-seeking behavior. And also it's very important to, like, in general, not really doubt a patient's symptoms or pain unless you have a very, very good reason to do so. In terms of a pneumonia, there's no sort of infective symptoms here, no history of purulent sputum or fevers. And then if we're going to talk about pulmonary embolism, it could be a pulmonary embolism, but this is a less classic history for a PE compared to a pneumothorax. So, you know, it's got very sudden onset pain. There's no sort of history of any risk factor for PE. So it could be, but it's more likely to be pneumothorax given the patient's demographic. It's particularly common in young males with cannabis smoking histories. So that's really what's pointing you towards pneumothorax over pulmonary embolism. So this is just a chest X-ray of a pneumothorax so that you can see how subtle it can be sometimes. You can see an area where there's absence of lung markings, and that's where there's the free air in between the lung and the pleura. It can be quite subtle, so I just wanted to show that to you so you've all seen one. Good. So next question. Five more seconds. Okay, so pneumothorax management is something that always gets me. You've got a pretty even spread here. Most people actually went for E. The correct answer would be A. So we can talk through that now. We've got a 22-year-old man with symptoms of a pneumothorax. There's no tracheal deviation. It's 1.5 centimeters in size on the chest X-ray. So he's symptomatic and it's 1.5 centimeters. So size and presence of symptoms are the two key things in determining management of pneumothorax. So it's saying, what's the first line management? You've also got to work out if the patient has a primary or secondary pneumothorax, so whether there's absence or presence of underlying lung disease. And here there's no history of that, so we're saying it's primary. So the best way to visualize this is probably to go through the flow chart, which is on the next slide. So this is from BTS guidelines. The first thing is saying, is the patient got evidence of underlying lung disease, or are they more than 50? So if yes, it's secondary. If no, it's primary. So we're going to go down the primary flow chart because that's what was wrong with our patient. Is it more than 2 centimeters, or are they breathless? So yes was the answer to that. So although the pneumothorax was less than 2 centimeters, the patient was symptomatic, which means we have to manage it through this way. So the first thing you would do in a patient with primary pneumothorax would be to trial an aspiration of the pneumothorax. And if that didn't work, then you would fit a chest drain. If the pneumothorax was very small, and the patient was entirely symptomatic, it would be appropriate to just discharge the patient with outpatient follow-up. Whereas if you're going down the secondary pneumothorax side of the algorithm, outpatient follow-up with discharge on first assessment is never going to be appropriate, because we're much more worried about these patients deteriorating. So if this patient had a secondary pneumothorax, we can go through. So if they would have been breathless, they would have gone straight to getting a chest drain. Whereas if they had been asymptomatic with a secondary pneumothorax that was 1.5 centimeters, they would have had aspiration. And then even if it had been tiny and they had been asymptomatic, they still would have needed to have been admitted for at least 24 hours of observation, because these patients are just very high risk of deteriorating. That's the main thing that differentiates primary from secondary. Next question. And 5 more seconds. A bit shorter question here. Great, so almost all of you got this right. So we've got a 73-year-old lady who's presenting with decreased exercise tolerance and shortness of breath. On examination, you found dullness to percussion, and on the chest X-ray, in keeping with your examination findings, you can see a unilateral pleural effusion in the right lung base. So what investigation would you do to try and find out the cause? Well, in any pleural effusion, the most important thing to do would be to aspirate it and test the sample for all the relevant markers, so that you can use Light's criteria to work out if it's transudate or exudate, and that can tell you and narrow down your differential to what's causing the effusion. If we just go through the other answers, a CT scan of the chest might be appropriate later down the line if you thought that there was kind of a mass or something underlying the effusion that you needed to investigate further, but it wouldn't be appropriate first line, because it wouldn't help you if the cause of the effusion was, for example, renal failure. And at this stage in the investigation process, you don't know that that's not the case. You've already done your chest X-ray. A BNP is very specific to cardiac failure as the cause, and for example, this might be parapneumonic or to do with inflammatory connective tissue disease, so it might not be appropriate here. And again, amylase is very specific to pancreatitis, so important to not narrow down your differential list too early. So a little bit about pleural effusion. It's fluid between the lung and the chest wall in the pleural space, not actually fluid in the lungs itself. That's pulmonary edema. So that's something that took me a while to get my head around as a med student. On a chest X-ray, you see this meniscal line, this gradual curve up, and that can show you that it's sort of a fluid level rather than lobar consolidation. And importantly, if you have a whiteout on a chest X-ray from a massive pleural effusion, the trachea will be pushed away from the side of the fluid, compared to a whiteout from total lung collapse, in which case the trachea will be pulled in because of the volume loss. On examination, as in the question, there's decreased expansion, dullness to percussion, and also if you were to auscultate, there would be reduced breath sounds. And then really the main thing to be aware of is Light's criteria. So you're looking firstly at the protein level. If it's less than 25, that tells you that it's a transudative cause. And if it's more than 35, that tells you it's an exudative cause. If you're in that grey area, that's when you need to use Lights to help you work it out. And generally, in terms of managing pleural effusion, you're going to put in an aspiration to get the sample, and then you might do that therapeutically to relieve some of the pressure off the chest and help aid the patient's symptoms. And if that doesn't work and it doesn't resolve, then you can do a chest drain to help drain it all out, and you can then take that out. However, if the effusions are recurrent, such as in malignancy that is palliative, then you might fit a long-term pleural catheter, so that's like a long-term drain that would just help keep the fluid level controlled. So here to talk about lights in more detail, that's looking at the aspirate protein level compared to the blood serum protein level. It's looking at the levels of LDH in the two fluids as well. And it's just basically working out whether there's higher levels of protein in the aspirate compared to the blood. If there are higher levels of protein, then you're thinking more infective causes or malignant causes, rheumatoid arthritis, pancreatitis, pulmonary embolism, whereas your transitive causes are like all the failures, someone once said to me. So sort of every organ failure can potentially cause a pleural effusion, most commonly cardiac or renal. Also, things that can cause pleural effusions are hypoalbuminemia of other causes, so like nephrotic syndrome or just poor nutrition. And then something called Meigs syndrome, which again is useful to know about for SBA land. That's a form of benign ovarian tumour, which can present with ascites and pleural effusion. And it's generally going to keep coming back unless you resolve the underlying problem, which is the ovarian tumour. Okay, next question. I'll give plenty of time for this one because it's very long. Five more seconds here. Great. So a majority of you got the correct answer, which is thrombolysis, with the majority of the rest of you going for the kind of next most appropriate thing, which would have been treatment dose low molecular weight heparin. So we can talk through the particular distinguishing factors for these things. So you've got a 30-year-old male who's come in with right-sided pleuritic chest pain, started suddenly, he's been on holiday, he's got no past medical or surgical history, and he's on no medications. From his observations, you can see he's hypoxic and he's got a very low blood pressure, 75 over 52. Then you've got a whole bunch of investigations that have been done. So a CTPA has confirmed the presence of a PE. The ECG is showing signs of right heart strain, and the echocardiogram is also showing this and demonstrating raised pulmonary pressures. So that's sort of directly evidencing the fact that there's a big clot in the pulmonary system. What's the next best step? So we can talk through the options. There's going to be a slide on D-dimer slightly later on. That's a test that's more appropriate where you've got a low clinical suspicion of PE. However, that's not going to be appropriate here when you've already made that diagnosis. It's going to be next to useless. Starting clopidogrel is something you would do under the ACS protocol. So if you thought those ECG changes were because of ACS, however, that's not the case here. You've got a diagnosis of PE. Prophylactic dose low molecular weight heparin is something you do to try and prevent people from getting a clot. However, this patient's very much already got a clot in his system. Treatment dose low molecular weight heparin is what you would do if this patient was not shocked and if they didn't have such clear evidence of significant strain on the right heart. However, because the patient's very unwell, blood pressure is very low, and there's significant evidence that the pulmonary system is struggling, it's really important that we thrombolyse this patient to try and actively break down the clot versus just treatment dose low molecular weight heparin, which prevents further clot from being formed, but doesn't have the same sort of strength of action in terms of resolving the current clot that's there. So if we go through our management of PE, the first thing you're going to do is resolve or try to resolve the hypoxia with oxygen, and you're going to give them some morphine if they're in a lot of pain, which they often will be, alongside the standard things that you need to give with your morphine, like an antiemetic. then the first and most important question you need to ask yourself is this patient hemodynamically stable? Are they at risk of crashing? And so if they are stable, that's when you give them their treatment dose, low molecular weight heparin. And if they are unstable, as in the previous question, that's when you can go down the thrombolysis pathway, as long as there's no contraindication to that. So there's a big list of contraindications to thrombolysis. It's similar to the HAS-BLED score in that there's kind of things that increase your risk of bleeding, and it's just important that you familiarize yourself with that list. But that wasn't the case with the previous patient, and he would have been suitable as far as we knew. So here you can see a CTPA. You can tell it's a contrast image because you can see the bright white within the vasculature. And then this dark area of absence of contrast, that's the clot. This is a big saddle PE that's sat across the pulmonary trunk. And then here, this is your Wells score. So there's also another score called a PERC score, which is being used more frequently, but the Wells score is still very much gold standard. And the critical value is 4. So if they've got a Wells score of more than or equal to 4, the system's more than likely to recommend you do a CTPA to try and make a positive diagnosis of a PE. Whereas if the Wells score is low, the PE is less likely. The system's more likely to recommend that you do a D-dimer to definitively rule out a PE and allow you to kind of put that diagnosis into a box, close the lid, and not think about that anymore. So just to talk about that in more detail, the D-dimer versus CTPA choice is something that's really helpful to think about when learning about sensitivity and specificity and trying to sort of contextualize statistics in terms of medicine. As I said, the value of a D-dimer is ruling out a PE. That's because the test has a very high sensitivity. So you can kind of think of this as like a really strong magnet for all the positive patients. It attracts everyone that's got a PE, so you're not going to miss anybody. However, the magnet's so strong that it also attracts a whole bunch of other people too who don't have a PE. So you end up with lots of false positives. But the people that you're left with who haven't been picked up, who haven't got a positive D-dimer, you can be 100% sure that they do not have a PE. And so that enables these people who have a negative D-dimer to be safely discharged, or, you know, to have definitively had that diagnosis ruled out. So yeah, high sensitivity, good for ruling things out. So I always remember sensitivity, snout, so SN, ruling out. So I find it quite difficult. So I use this kind of aid memoir of spin and snout to remember the use of specificity and sensitivity respectively. In terms of a CTPA, the opposite is true. So this is the gold standard for making a positive diagnosis and for ruling a PE in. It's because it's got a very high specificity. So you can kind of think of this like a super accurate filter. So it filters out all the patients who don't have a PE until the people you're left with are people who you can kind of directly visualize the plot, you know they've got a PE, and therefore it warrants doing things like thinning the blood or giving thrombolysis, things that are more risky and that you wouldn't want to do for just everybody if you weren't certain of the diagnosis. So specificity, SP, spin, so the value of tests with high specificity is for ruling things in. So lots of people will ask, why wouldn't you just do a CTPA for everyone? Because it's a better test, and that is true, but it's also much more expensive using a CT machine compared to doing a simple blood test, and it comes with a high radiation dose for the body, so you're going to try and avoid that if possible. So that's why you would kind of start with a D-dimer beforehand if you had any kind of doubt. And then this is just a nice flowchart which shows you, so clinical probability is the most important thing for a PE. When you look at your Wells score, the thing that's going to give you the most points is another diagnosis more likely than a PE? And that's responsible for 3 points. That almost makes you up to your score of 4, which is needed to warrant a CTPA. So if you've got low or moderate clinical probability, that's when you're going to go down your D-dimer pathway and act according to the D-dimer result. Whereas if you're kind of thinking before you've even done anything with this patient, like, oh, this really looks like a PE, and you've got a high Wells score, that's when you're going to go down your high likelihood pathway. And in these patients, actually, if you're very concerned, often treatment dose low molecular weight heparin will be started while you wait for the imaging to be done, because there might be a delay of a couple of hours and you might not want to risk that the patient will deteriorate in this time. Okay, so this is the final question now. I'm going to give you lots of time to read this one because I personally think this is a very difficult question. So take your time. Okay, 5 more seconds. Okay, as I was kind of expecting, you guys struggled with this question. Most of you thought that the correct answer was D. The correct answer is actually B. So let's talk this through in lots of detail and work out why that's the case. So you've got a 70-year-old man with a 20-pack year smoking history, 4 months of weight loss, cough, you've got some bloody sputum. He complains of some night sweats. He's noticed he's been very thirsty. He's been passing lots of urine, but he's also been having some constipation. And he scores 6 out of 10 on his abbreviated mental test score. He also has some clubbing. Which of the following would be specifically associated with the diagnosis? So when I read this question, what it's actually asking you is, what type of lung cancer does this man have? And then what the options are different syndromes and symptoms that are associated with different forms of lung cancer, but only one of them is associated with the particular type that this patient has. So we're going to go through this in loads of detail. But basically from this question, you can see that the patient's got signs of hypercalcemia. So he's got his increased urination, his constipation, his psychiatric symptoms. So, you know, your bones, stones, abdominal groans, psychiatric moans. And he's also got clubbing, which is meant to represent this hypertrophic pulmonary osteopathy, which can cause clubbing, as well as that just being a thing that can happen in patients with lung cancer. So this is getting you to think towards squamous cell carcinoma, which is the type of lung cancer with which hypercalcemia is associated. It's the most common type of lung cancer in the UK, and it can be strongly associated with paramalignant pneumonias. Just the extra importance of doing that 6 weeks follow-up chest x-ray. It can cavitate more so than other pneumonias tend to do so, and you can see that on this chest x-ray example that's been given here. And this is the value of doing CT scanning, because when lesions cavitate like that, it can be quite hard to tell whether it's a mass, whether it's you know, something infective such as from TB with a granuloma, whether it's an abscess. So the CT will tell you that in more detail. It can spread locally very aggressively, but it's actually less inclined to metastasize until later on in the disease process. And it can release ectopic parathyroid hormone analogues, which cause bony destruction elsewhere in the body. And as a result of that, it causes hypercalcemia as the calcium is released from the bone. So that gives those symptoms in the previous question. And alongside that, it can also be associated with something called hypertrophic pulmonary osteoarthropathy, which is a particular sort of periosteal bone reaction. The actual underlying bone isn't damaged, but the periosteum lifts and becomes inflamed, and you get what's called an onion skin appearance on an X-ray. So definitely worth looking that up in more detail. Although it is quite niche, it's definitely important to know, as it can help you distinguish between different types of lung cancer from clinical questions. Just to go in a bit more detail about other types of lung cancer, you've got your adenocarcinoma, which is, as with anything that says adeno in the name, comes from a glandular epithelium. It doesn't tend to cavitate really, and it's actually the most common form of lung cancer in non-smokers, and particularly in women with certain types of ancestry, Far East ancestry, and yeah, as I said, least likely to be related to smoking. So if your question stem says that you've got a non-smoker with lung cancer, the most common kind of subtype would be adenocarcinoma. Then you've got your mesothelioma. It's quite rare. It's a cancer of the pleura. You can get pleural plaques on a chest X-ray. It's worth Googling that just to see what that looks like. And it's the one that's caused by asbestos exposure. Although not everybody who has been exposed to asbestos will develop mesothelioma, but basically everybody who has mesothelioma has had asbestos exposure. So that's what I mean when I say interesting relationship. And then finally, small cell carcinoma. So this is the type of lung cancer that's most associated with your endocrine paraneoplastic syndromes. Basically everything except the hypercalcemia and the PTH axis, because that is from the squamous cell carcinomas, as we just discussed. So here you can get Cushingoid appearance due to ACTH production. You can get hyponatremia and syndrome of inappropriate ADH secretion, because you can get some ectopic ADH production. You can get something called LEMS, Lambert-Eaton myasthenic syndrome. It's a bit like myasthenia gravis, but shows the opposite in terms of fatigability. So instead of myasthenia gravis, which their amplitude of movements will gradually reduce because they get tired with repetitive movements, people with LEMS will actually increase in their amplitude and their strength on repeated movements. So that's on examination a really important differentiator. Small cell carcinoma is also the most common cause of a Pancoast tumour, which is another thing that often comes up in SBA land. Pancoast tumour being an apical lung tumour that can invade into the brachial plexus and cause a Horner's syndrome. And generally this type of lung cancer, small cell carcinoma, has quite a poor prognosis. It's almost always inoperable because it's metastasized very early in the disease process. So by the time you find it, it's quite developed. However, although it's not usually susceptible to surgical intervention, it's one of the few types of lung cancer that's very chemotherapy sensitive. So that's usually the route of management that patients go down. Okay, so that's the end of the session. Thanks so much for coming.